Okay, we'll just raise my voice. Assalamu alaikum. Jazakumullah khair. Sorry for this technical issue. Please, next time we need to be, everything should be ready for streaming. This takes so long. Today we'll talk about visual field interpretation in glaucoma. Yeah, it's another issue also. Okay.
Presenter view of space, okay? Swap presenter view slide.
I also have my notes in the presenter view. This is a problem. It should be fixed before that. Okay, so today we'll talk about visual field interpretation, mainly automated perimetry, which is most commonly Humphrey. This is the static perimetry. If you have time, we'll talk about kinetic visual field interpretation. So as an introduction, there's a saying that visual field is an island hill of vision in a sea of darkness. As you can see in the image, this is the visual field. The highest point is the high sensitivity, which is in the macula, and gradually decrease until the periphery, and then the sea of darkness is beyond our visual field. The normal visual field usually extend superiorly 60 degrees, inferiorly 75 degrees, temporally 100 degrees, and nasally 60 degrees. First, we need to understand few terminology before we start. The scotoma is an area of visual field where an object cannot be seen, surrounded by normal visual field. There is two types, absolute and relative. Absolute, when the retinal sensitivity is nearly absent and there is no object can be seen, like in the blind spot. The relative type is when the retinal sensitivity is reduced as compared to normal. Larger and brighter object can be seen in this scotoma. This is the relative scotoma. As you can see, decreased sensitivity, but still some high bright objects can be seen in this area. But the absolute scotoma is complete absence of retinal sensitivity, same as the blind spot. Threshold, the differential light sensitivity at which a stimulus of a given size and duration of presentation is seen 50% of the time. In practice, it's the dimmest spot detected during the testing. Sensitivity, most subtle characteristic of a stimulus that is visible at a specific point in space. Fixation is the part of visual field corresponding to the fovea centralis. Isopters, this is for the kinetic. I will skip for the sake of time. Parameter is an instrument that measures the visual field by the patient's subjective response, and is used to detect the visual field changes and monitor changes in previously known condition, for example, progression. So there is two types of visual field testing, kinetic and static. The kinetic, the stimulus is moving from outward to inward, usually when from non-seeing area to seeing area, and once the patient sees the stimulus, we will mark this site. The static, usually the light is stable, but the intensity can be changed in the same site, as in Humphrey visual field. This is the Goldman on the left side and the Humphrey visual field on the right side. The automated perimetry, most common machine we use is the Humphrey. So I'll talk about it mainly. The threshold program. So the machine measured the threshold in the full threshold strategy by starting with high intensity stimulus and decreasing by 4 decibel. Decibel is the unit that measures the intensity of the light. So the machine starts with high intensity, and once the patient sees this stimulus, it will decrease by 4 decibel until the patient stops seeing this stimulus, and then it will go back and increase the stimulus by 2 decibels, and then until the patient sees the stimulus, and then it will mark as the threshold. Threshold tests determine the minimal brightness that patient can see at a given location of the visual field. Screening tests, super threshold test. This uses a very bright light at the beginning with the 6 decibel levels above the expected threshold, giving the patient age and giving the location of the stimulus. So threshold test, usually in glaucoma, we use 30-2 and 24-2. The difference in the first number, 30 means 30 degrees from the fovea, and 24 degrees from the fovea, and also 24-2 is extended nasally to detect early glaucoma change in the nasal part. 2, the second number, determines you can use only 1 or 2. 1 meaning that the testing area is overlaying the vertical and horizontal gradients, as you see in the first image. And -2, that means there is 2 spots tested around the vertical and horizontal, and we use this to detect if the scotoma crossing or non-crossing the midlines. So techniques and strategies, we have a full threshold strategy. Start with super threshold stimulus at each location, and this results in a long test time. And this is the standard test. To shorten the duration, we can use fastback and CETA. Fastback is the same as full threshold, but it uses 3-signal reverser that can decrease the time, but also can underestimate visual field effects. The CETA will talk about it. And for the early detection of glaucoma, we have also 2 strategies we can use: the SWAP, the short wavelength automated perimetry, and frequency doubling technique. The SWAP stands for the Swedish Interactive Testing Algorithm. Depending on the reduction, develop to reduce the time while maintaining accuracy in automated perimetry. Utilize Bayesian rule of probability to minimize number of stimulus. CETA utilize specific factors like age, location of field threshold at adjacent location to predict the probability of threshold level at any given point. So basically, it uses complex mathematical measurements to predict the threshold before starting the test and minimize the number of tests at each point. We have 3 types of CETA. We have CETA standard, CETA fast, and CETA faster. The CETA standard is usually 7 minutes per eye, and the CETA fast is 4 minutes per eye. We can use it in 24-2 and 30-2. For the short wavelength automated perimetry, or SWAP, it uses a blue stimulus over a yellow background. The blue stimulus activates the short wavelength sensitive cones, and these cones are usually affected first in glaucoma. What is the benefit of SWAP? Early detection of visual field loss in primary open-angle glaucoma. Why? Because the short wavelength sensitive cones are damaged early in glaucoma, and we are capable to detect damage earlier. Defects in high-risk eyes may appear up to 3 years earlier than white-on-white automated perimetry. Often these defects will show the same location later on with white-on-white. However, the blue light can be absorbed through the media. Patients have cataract, patients have macular disease. This can be inaccurate. So the visual field, the Humphrey visual field printout, we can divide it to 10 zones so we don't forget anything. As you can see, this is the sheet. We can divide it into 10 areas. The first zone is the data, patient data, and the test data. The second one is the reliability indices, as you can see here. Third one is the raw data or numerical raw data. This is the grayscale for the raw data. We have the total deviation, numerical and plot, and also pattern deviation, numerical and plot. We have the global indices and the glaucoma hemifield test. For zone 1, patient data and test data, we should check always the name and the MRN number to make sure that this is the accurate, the right patient. Pupil diameter, visual acuity, and refraction. Refraction is very important. If we have if we missed 1 diopter of refraction, it will decrease the sensitivity by 1 decibel. And the test data is also important. Most important one is the test strategy. If you want to compare 2 tests, it should be the same strategy. Fixation losses for the zone 2, we have the reliability indices. The first one is fixation loss. During the test, 5% of the stimuli will present on the blind spot. The patient response to this stimulus is due to shift in fixation. So when the lights shine in the blind spot and the patient presses the trigger, that means that he moved his eyes and will be counted as fixation loss. Fixation loss more than 20% is considered unreliable test. False positive response. If the patient pushes the response button to an unprojected stimulus, for example, the machine sometimes will produce a noise without a stimulus. The patient reacts to that, this will count as false positive. Up to 20% is considered acceptable, and more than 33% is unreliable test. False negative response is failure to respond to the brightest stimulus in the area previously determined to have some sensitivity. So high false negative may indicate lack of attention or fatigue. So if the machine tested one area, the patient responded, and then retested the same area, the same intensity or higher, and the patient did not see the stimulus, that will be counted as false negative. If the patient is fatigued or tired or not interested, usually false negative will be high. If it is more than 33%, the test is unreliable. Although we cannot depend only on false negative, some patients with advanced glaucoma, they will have high false negative. Gaze tracking, we can find it in the bottom of the sheet. It will show, it uses infrared gaze tracking system. If the graph has upward deflection, that means deviation at the time of stimulus, which means eye movement. Downward deflection is inability to determine the gaze during the stimulus, for example, blinking. So zone 3, we have the raw data. The raw data is the exact retinal sensitivity in decibel. When you have 0 in that the raw data, that means there is absolute scotoma. There is no sensitivity at all in that area. We have the maximum, which is 40. That means the patient responds to the dimmest light possible by machine. The grayscale, it is the numerical values of the raw data in decibel unit are presented graphically. So the machine takes the numbers and convert them to colors to simplify them. And the machine does not use any statistical calculation or numerative analysis, so we don't rely on this scale for diagnosis. It is a good tool to show the patient the severity of the disease. The patient have high false positive. The grayscale will show white area. That means when the patient press when there is no stimulus, it will be completely white area, as you can see in this color here. High false negative, patient have high false negative, they will sometimes show a clover leaf appearance, which you can see here. Mainly the peripheral field is is affected. Zone number 5, total deviation numerical plot. So in this graph, it will show the raw data compared to the normal age group of the patient. For example, it will take the decibels measurement of the patient and compare it to the same age group. If it is the same, it will be 0. If it is less, it will be minus. If it is more, it will be plus. And for the total deviation probability plot, it's the same as the numerical value, but converted to p-values. What does that mean? That means it will show the significance of each dot in terms of the difference between the patient and the his normal age group. If we have p-value of less than 5, it will show 4 dots like this. If we have less than 2, it will be like this, and so on until less than 0.5, it will be complete dark square. Is this clear? Is it clear? Anybody wants me to repeat? It's very important to understand.
You will have a quiz after this, so please, if you have any questions, then time to ask.
So total deviation, I will repeat again. Total deviation, it will the machine will take the score of the patient and compare it to normal age group, and they will it will give it a score in the numerical graph. And this one here. If the patient scores 0, that means he's normal. He's scored plus, that means he's above normal. If he scored minus, that means below normal. And the probability will show the probability of this result. Is it due to chance or is it really significant? If it is dark, it means it's really significant. So he's far away from the normal. Okay. There's a problem with this graph. The deviation value for more than -8, for example, from -8 to -24 decibel, it has all of this has a p-value of less than 0.5, which is dark square. That means there is a wide range of that can show this dark square, and we cannot tell the depth of this defect. So we have the pattern deviation to correct that. So pattern deviation is modified from total deviation numerical plot to bring bring out deep scotomas. How does it do that? You can see here the machine will select the 7th best retinal sensitivity point in the total deviation numerical plot, and will bring this 7th best retinal sensitivity to 0. And then we'll see how much it needed to correct that, and we'll apply it for the whole chart. For example, you can see here if this is the total deviation, and this is the pattern deviation. In the total deviation, patient scored in this point -6. The machine wants to, let's say this is the 7th best area. The machine corrected it until it became 0, so it added 6. We see the other points here, -7, it added 6, became -1. This one the same, -8, added 6, became -2. So mild and moderate degree of decibel deviation are eliminated, and only greater degree of decibel deviations are highlighted in the pattern deviation numerical plot. Is clear? Yeah. Okay. So imagine that we have a test for students. Okay, we have students that they did the test, and most of them failed. Okay, this is the same as the total deviation. If we have a lot of dark spots, that means most of them are failing. We want to know which are really did not study for the exam, really bad for the exam. So we put a curve for the students. This curve some of them will pass, and some of them will still fail after the curve. We want to see this group in the pattern deviation. So the pattern deviation probability plot is the same as the probability plot for the total deviation. It shows the p-value for each measured retinal sensitivity, corrected for generalized visual loss. So when we have cataract, the total deviation will be decreased. The whole sensitivity, the whole retina will be decreased. But in some area, there is hidden scotoma. Under that, some area, this scotoma will be deeper than the others. So when we do the pattern deviation, it will increase the whole retinal sensitivity and will show the real scotoma and eliminate the generalized loss. Same here in this exam. This is the total deviation, and this is the probability plot of it. You can see all areas are dark, all over here. We don't know where is the scotoma, the real scotoma. When we see the pattern deviation, we can see when we increased the sensitivity, all of this area gone. Now the real scotoma showed up. It's here. The global indices is a basic global field indices. We have 4 of them: mean deviation, pattern standard deviation. These are the most important. We have the short-term fluctuation and corrected pattern standard deviation. So change in retinal sensitivity will affect either the height of the hill of vision or the smooth contour of the hill of vision. You remember the hill of vision we talked about in the beginning. So if the whole hill of vision is reduced, the mean deviation will be low. If the contour, the shape of the hill of vision is changed, the pattern deviation will be increased. So this is the mean deviation. Is an average. It is an average of all numbers shown in the total deviation plot. You remember the total deviation plot, the first one, without correction. The total deviation plot comparing the patient scores to normal population. So this is an average of all of this. That signifies an average of overall sensitivity of visual field. As you can see here, this is the normal, the above, and this is the patient visual field. And the shape is the same, only the height is changed. So in this case, the mean deviation will be low. The normal is up to -2. If more than -2, that means there is mild visual field change. If it is from -2 to -12, we'll consider it as moderate. If more than -12, we'll consider it as severe. You can see this is mild, this is moderate, and this is severe. Okay. Pattern standard deviation expressed the regular loss of retinal sensitivity. It's either 0 or positive. Okay, if it is 0, it means the shape is normal. Doesn't mean the visual field is normal. It means the shape is normal. There's no deep scotomas. There's no specific scotomas in the visual field. If it is positive, that means there is some scotomas in the visual field. There's some area decreased comparing with the normal. Okay. As you can see here in the shape, we have this deep scotoma here, and the contour, the shape of the visual field is changed, so the pattern standard deviation will be positive. High pattern standard deviation may be due to low patient reliability or actual visual field effect, or both. Okay, is it clear? So the mean deviation is the same as total deviation here, and the pattern standard deviation is similar also to the pattern deviation here. Okay. This type of visual field, we have generalized depression. We expect in this type we'll have low mean deviation. Mean deviation will be affected, but the pattern will not be affected. Okay, and we'll have abnormal total deviation plot, the first one. And when we have localized focal defect, we'll have high pattern standard deviation and abnormal pattern deviation plot. Okay, when we have both of them will be affected. Mean deviation will be low, meaning affected, and the pattern standard deviation will be high, meaning it's affected, and abnormal total and pattern deviation. Short-term fluctuation is an index of intra-test variation. At 10 pre-selected points, the retinal sensitivity will be calculated twice. Measurement of reproducibility of the response. That means if there is 10 points in the visual field, the machine will measure it 2 times in the same intensity, and will compare the results. If there is high difference, that means either the test is unreliable or there is early glaucoma. Corrected pattern standard deviation is intra-testing variability with using the short-term fluctuation and remove the pattern standard removed from the pattern standard deviation. That means we need to have short-term fluctuation to have corrected pattern standard deviation. We will remove these area where machine measured twice, and if there is difference in this area, we will remove the same amount and we'll have the corrected pattern standard deviation. Corrected pattern standard deviation. We need to know, we don't see this a lot in the visual field test, the short-term fluctuation and the corrected pattern standard deviation, because they are only there with the full threshold test and fast back test. The CETA test does not use the short-term fluctuation, so it cannot calculate the corrected pattern standard deviation. The last one is the glaucoma hemifield test. The glaucoma hemifield test evaluates 5 zones in the upper field and compares them to their mirror image zones in the lower field. So take these 5 fields, take the numbers patients scored in these 5 fields and compare them to the lower fields. Usually there is 1 to 2 decibel difference, being the superior part lower by 1 to 2 decibel difference. This is normal, but more than that, the machine will flag it as abnormal. The possible outcome of the possible result of the glaucoma hemifield test, it will show either within normal limits, that means there's no difference, or borderline, that means the difference detected would not be found in 97% of patients without glaucoma, or outside normal limits, they made the difference. The upper and lower sets of points would not be found in 99% of patients without glaucoma. So we can use these criteria to detect real focal or generalized defects in the visual field. For the focal defects, we need to have 3 non-adjacent points in total or pattern deviation probability plots. One of them, or two points of them having less than 5%, or 1 point having less than 1%, or having highest pattern standard deviation, or having abnormal glaucoma hemifield test. For the generalized, we can compare the mean deviation between both eyes. We need to have 2 decibel difference in the mean deviation index. We need to have a 1.5 decibel difference in mean deviation index in 2 consecutive tests, or an average difference in as small as 1 decibel in 4 consecutive tests, and or high short-term fluctuation. Sometimes you can have artifacts in the visual field. You can divide them into behavioral factors and physical factors. Behavioral factors like learning curve, patient doing the visual field for the first time, usually they will have some defects. With time, when you repeat the test, usually these defects will go away. Fatigue effect, as we described earlier, they can have the cloverleaf appearance. False positive effect or habit trigger patient will have white visual field. Physical factors like trial lens power, as we mentioned before, we need to check refraction and the trial lens position. If the position of the lens is not correct, they can have rim effect. Rim of the lens will show peripheral scotomas. Sometimes patients have ptosis, they will have also some visual field defects. Head position and body position is very important. If the patient is not well positioned, they will get tired and they will not do the test properly. So to classify disease severity by visual field, we depend on two factors: the mean deviation, as we described earlier, and also the position of the scotoma. The closer the scotoma to the center, the more severe the disease is. If the patient have paracentral scotoma, even if the mean deviation is mild or normal, it's considered as severe because it's threatening the vision. Always we need to correlate our clinical finding with the visual field. Anybody knows the name of this map? These two images here. Yes, correct. Galway here is very good maps you can see to help you to predict where the visual field defect will be. Types of glaucomatous visual field defects. We can see nasal step, temporal wedge, arcuate scotoma, paracentral scotoma. You can see also, like this one, paracentral or threatening fixation. And we can see altitudinal. In advanced cases, we have generalized depression with central island. At the end, we have complete visual field loss. There are simple few cases just to help us to understand more. Let's see. Sad. Okay. طيب, we have Saeed. What do you see in this image? Yeah.
Please raise your voice. Coming, you all take this.
Okay. Do you see any notch?
Yes.
Where? See here? It's very thin rim here, very thin. If we apply the Galway here, where do you think the field effect will be? So this one here will be here. Fine. Correct. It's superior thinning. We have inferior visual field effect.
But blood vessels in skin superiorly, you see.
Yeah.
Clearly, so you can see it's the area of the nose. Just follow the blood vessels.
Okay. R1 is R1. Cover. Same thing. Yeah. Same thing. What do you think here? Temporal? Yeah, it's inferior temporal here. Maybe the image is not clear. Here the rim is very thin rim, almost total in this area. So if we say the thinning is here, where do you think is the field defect? Where? In which color? Here, we say that here, we red, a little bit dark, black, will be here and here also. You can see in the photo. طيب, who's Rahman? Do you think that this test is reliable? 7 out of. Okay. What do we need to do here?
You think
Okay. So can you read the field now? Yes. First, zone 1, you check the patient name and the correct patient, and check the date of birth, check the age. If the age is wrong, all of this is wrong. make sure the edge is there. That's correct. And also refraction. And what else? See the strategy. Need to mention it. You see, this is the CETA standard visual field for the right or left eye. Okay, and the reliability indices. What do you think? Okay. And then next, what do you want to see? Yes. In which chart? Which plot? Hmm? What is the name of this chart here? Or this one?
What's the name of this chart, Abdulrahman? What about the charts down? Yes.
هذا وشو؟ وهذا؟ هذا؟ The gray scale وهذا النوميريكال حق نفسه. هذا الرو داتا النوميريكال وهذا الجراي scale. Okay. So what do you see here? Total deviation. Okay. What happens here? So what do you call this superior scotoma? Okay. And well, how about this one? Superiorly, any changes? Yes. Okay. And next, what do you want to see? Okay. We need also to comment on it. Here it's minus 19.5. What do you think about it? Is it mild, moderate, severe? Severe. So you say this mean deviation shows this number, and it is severe glaucoma. Total standard deviation is 12. I think it's normal. So also 12 is very high also. And how about the glaucoma hemifield test? Yes. So as you mentioned, showed generalized depression with pattern deviation cleared at the inferior arcuate and the spiral nasal. You mentioned the pattern deviations, mean deviation, glaucoma hemifield, and this is advanced glaucoma defect. So in this case, we said we can classify the severity in mean deviation, and what else? There's something else we can indicate the severity of the disease. Yes, central or paracentral or reaching center. What do you think here? It's reaching center or not? Yeah, so when we see this, it's called split fixation. It's reaching the center. What do you want to do next? Maybe another resident can change.
What do you want to do next?
I believe we want more another test.
Yes. The same test or different?
It's different.
Okay. But we want to make sure that this field is reaching the center or not. What we can do?
You change your protocol.
We might do 10-2.
Correct. Yes. So we do 10-2 to make sure is it reaching the center or not. So this is 10-2. So what do you see here?
There's an inferior.
Yes.
It's
Very good. And this is 10. We want to make sure, usually we comment on the 5 degrees of the fixation. It's not reaching 5 degrees. This is good. The means is good. It's not reaching the 5 degrees of fixation. Yeah, it is advanced. It is reaching beyond 10 degrees, but there is still 5 degrees from the center. The same thing here. The total deviation is completely affected. The pattern only shows the real scotoma here. Here in the 10-2, we have -8. Previous was -19. Why is that?
What is it now?
-8.
I don't know why it's
Why is it better? Okay.
yes. Why in 10-2 it gets better?
Yes. The amount of scotoma here, is it the same? You see, you can see the grayscale even. See the amount of scotoma here. It's much less than this one. Most of the area here is affected. So the mean deviation, when we rely on it in the severity, we consider the 24-2. Once we reach 10, it's already severe. It's severe glaucoma, regardless. So we can rely on it on follow-up. For example, with this patient, we will follow him up with 10-2. But we will see the mean deviation, or see the pattern deviation for the follow-ups. Okay? Yes.
What is the blind spot here? What is the blind spot? Outside.
Yes.
Why is outside? So why you cannot see it? Outside our field. So where does the blind spot locate? Yeah, so optic disc is how many degrees from the fovea, location of the optic disc. Anybody knows? Say, what's that? 15. 15, yes. So actually you will never see the blind spot. It's in the 15 view. 15-2 or 16-2 you will see. But less than 15, you cannot see the blind spot.
So for the kinetic Goldman visual field, we will not discuss it today, but we'll continue with cases. Let's see, Muhammad, can you read this field? Start with the right eye.
First objectivation data. Starting with right eye. Compare data for first check the is reliable.
Okay.
Check reliability.
Yes.
There's your policy.
I'll check the reliability and we'll see the type of the test as well.
Okay.
And see, well,
This CT standard.
CT standard.
And how about the reliability? Is it okay?
Fixation loss is 1 out. Is it
15? Yes. 1 out of 15.
You can stand with it come closer. So.
Yeah.
So the fixation loss is 1 out of 15 with a false positive error of 1% and false negative error of 4%, which is considered reliable.
Okay.
Then we'll see the age of the patient confirmed as well. See if there is any refraction people there.
Yeah, this is the first step there. First, the data, you can see the patient data and the test data. Then you finish and you go to the reliability indices. You don't go back. So you just say this is a CT standard test 24-2 for this age patient. I can see there is refraction and the you can say it for the also the pupil diameter and all the others you can skip. But the reliability indices, then you You go to reliability test and you comment on each one and you say this is reliable or not. And then next, where do you go?
We'll move to the third part of the test, which is the blocked channel, and this is the numerical data, and this is what the paragraph summarizing it.
What's the name? I told you to read before we start. All the listeners should read before we present. So they need to understand the basic, so we can understand the whole picture. So this is grayscale. Grayscale. This is numerical raw data.
So,
What does it show? The grayscale.
it's showing your critical superior defects.
Okay.
Zero nasal, with the nasal step.
Okay. And next, where you go?
I'll go to the total deviation plot and the pattern deviation.
Okay. And what do you see then?
Showing the same. Mainly a superior archway.
Yes.
And the pattern deviation is going with that as well.
Okay. So there is no difference in pattern or total. What does that mean? Sometimes, same as the cases we saw before, total is more affected than the pattern. But now they are the same. What does it mean?
Why they're not the same?
Sorry? Yes, what do you call this? Cataract, coronary scar? Yeah, it will cause generalized depression, media opacity in general. Okay, so they are the same because there is no media opacity, there is no generalized depression. Only these scotomas are real and it shows the 5% deviation. Because when we correct them, it's still the same because they are deeply affected. And next, where do you want to go?
Go to the Glaucoma thesis.
Okay, and how to comment?
Deviation is -3.
Okay.
It's considered minor. PST is
2.4.
2.12. Considered as well.
What's the normal for pattern standard deviation?
Around 0. It's more
Yes.
than,
Yeah, more than 0 is not normal. Yani 0 is the normal because this will, if the visual field shape is normal, so it should be normal. If there is any scotomas, irregularity of the shape of the visual field, it will be positive. So, is this glaucomatous change or?
yeah, this is glaucoma.
Okay.
Glaucoma
Glaucoma hemisphere
an outline.
outside. Okay. How about this one? Is it okay?
For the same patient, showing the left eye compared with the
Yes. No need to read it, but tell me, is it normal or
yeah, it's normal.
any thing is missing in this field? Anybody can find there's something missing in this field. What is it? We say this is normal field, but there's something missing. Yes, blind spot. Blind spot is not here. Why is that?
Fixation is good.
Okay, this one thing, yeah, if the fixation is high, it can give you that. That's one other thing. A patient should not see in the blind spot, but if they see, what does that mean?
trigger happy.
Yeah, they can trigger happy if you have high false positive, but it's not zero here. You can see the tracker, gaze tracker. Okay, you can see the high movements here compared to this one. Okay, thank you. Do you have time for one?
Yeah.
طيب, who's next? Yeah. Who wants to take this? Who wants to volunteer?
Yeah. Go ahead.
This is the staff patient came, age, ID, and identity, to activity, is what was corrected on this is 24-2 city standard test.
Sit fast.
City pass, I will start from the right eye. The reliability increases, session was less than 2, which is super reliable. False positive 33%, which means not reliable. Extra raw data, the grayscale show superior spectrum.
Good.
Total deviation.
Mhm.
There is the superior and inferior deviation. When I talk about the standard deviation, superior and inferior deviation. The mean deviation is 15.
Minus 5.
Minus 5.
Minus 5.4.
There is my changes under standard deviation positive. So it's
Okay.
glaucoma field distance outside.
Okay. And this one, do you think is the glaucoma test damage also? Which one is more severe? Why? Yes. So mean deviation here is more. It mean because the scotomas here are deeper. You see the color is deeper. Okay. And although it's mainly superior, and here he has both inferior and superior, but this is more severe, and the cupping here is more. Right. طيب, who's next? Aziz, yeah.
Okay, this is the unfavorable field.
Let's start with this one. Yes.
First, I'll confirm patient and I'll confirm patient name, ID, and age. Then I'll check the reliability, which is good. There's no fixation loss. False positive and negative are 0. Then I'll confirm the type of test and the angle. It is theta fast, and I'll then check the grayscale for any generalized depression. This is the left eye, and the blind spot is in the temporal side. The shows that the blind spot is somewhat enlarged. The total deviation also somewhat responds to the pattern deviation. So I wouldn't expect a huge difference because of any media artifact or such as cataract.
Is it the same, or I think there's
It's different.
Yeah.
So the pattern standard deviation is 2. The patient might have some media opacity or refractive error. The mean deviation is minus 3.38, which is reduced mildly.
When you have a positive pattern standard deviation, what does that mean? Can you remind me?
That there is something affecting the vision other than the glaucoma. It might be
The pattern standard deviation. It's not the pattern deviation. plot here. We have positive pattern standard deviation here.
What is the difference between 2 points in the pattern deviation? The difference.
If we have positive,
intensity
it
between 2
means cataract, or it means scotoma, or it means
It is positive, it is other than spectrum.
okay.
Maybe you cataract or medium.
Right. Let me explain this again. Just so the pattern standard deviation, when it's positive, that means there is scotoma. The shape of the visual field is irregular. There is scotoma in the visual field. Okay. The pattern deviation plot. Okay. Pattern deviation plot, numerical and the probability plot. It will be better than total deviation if there is media opacity. Okay. So these results here, the patient results compared to normal population. Okay, and he scored less here and here and here and here. All these areas he scored less than normal. But when we give him a curve for his test, some points passed, but some still failed. That means these points are really poor. These points are really affected. But these points, little bit affected. Maybe these points are related to media opacity, like cataract, cornea opacity, whatever. So when we have pattern standard deviation, that means there's effects suggesting glaucoma or any other pathology. And the hemifield, it's abnormal. What do you think about this test? Is it normal? Is it abnormal?
So no.
Yeah. So yeah, there is defects here and consistent with the pattern deviation, and the mean deviation is affected, pattern standard deviation is affected. This is abnormal, and it looks like reliable. 6 months later, patient had this visual field. Why do you think this happened?
So the test here is also reliable. It's less reliable than the first one. Deviation worsen.
Yes.
-3 to -6.
In general, it is worse here. It's more scotomas, and everything is worse. Why do you think it's happened?
Might be progression.
Okay. Good. What else? Can be something else?
The reliability is less than the first, so it might be a cause.
Okay, let's say it's reliable. Anybody? Hamid? Yeah, okay. This, yeah, the duration is longer, but it's reliable.
Would be the refraction?
Yeah, this could be, but maybe his refraction
If it's
changed.
refraction, do you expect local or total? Total. So
Yeah.
there's increase in the
The test is different from CETA
Yeah.
fast to CETA standard.
Yes. So we need to do the same test. Here is theta fast and here is theta standard. We need to do the same test. Okay. Let's say this. We said this is normal because of the theta standard and theta fast. Let's just follow him up. Can we follow him?
See the duration of the test.
Yeah,
It's
the
1
duration.
minute, and here 9 minutes. This gives you an indicator that the test protocol is different.
Yes. So if you see like someone like this, you will what will?
It should be the same test. I should repeat CETA fast or
Okay.
give another follow-up and use CETA standard.
Would you consider this is progression or no? No.
Rely on 2 different tests
Right.
to diagnose this.
So you give this patient another 6 months and he came with this. He did another CT standard. He came with this.
Yeah, CETA standard, reliable, so this is progressive.
And look at the previous
6
one.
months.
You have progression even if you have different tests. you should repeat soon. You don't just leave the patient and blame it on the test. Okay, so he was progressing. But if we blame it on the test and we give him 6 months later or 1 year, he will come like this. Okay, if this test was same or better, I would keep him and see him later on. But if it's worse, we need to dig and see if it's really worse or not. Should not keep the patient. Okay. Okay, who wants to take this? See, it's different machine. What else? You have to look, see the standard, see the fast, full threshold. طيب, you say it's reliable, and what you want to see?
It's showing increased brightness.
Hmm?
Increased diameter.
Is it really increased?
What's the definition of increased blind spot? So how you say it's increased and you don't know what's the definition? Okay. Cool. So let's assume it's not increased. It's generalized depression.
Where do you see the generalized?
In the grayscale. Is it? It's not the clear line.
Should not be. It's white, it means the patient is happy triggers, having high false positive. Should be gray. It's called the grayscale.
Do you think grayscale should be white? At this moment.
Next, what do you want to see?
In the standard.
What is this?
What do you see in that total deviation? Do you see some change? Would you describe this? Yes, describe it. What did it mean? Is it nasal? No. Where is it?
How about the pattern?
Let's go. Could you help him, please? What's the definition of scotoma? So you will pass this test within normal limit. You will tell the patient, go home, you are normal. It's okay, it's not.
Okay. So you're happy with this test?
So you are happy with this test, right? Do you have a health insurance? Do you have a malpractice insurance? So be careful if you pass this test as a whole.
to be ready to go for that.
Cool. Anybody can help? I think Khan maybe he's the one who can. Yeah. So describe what you see. This is a visual field. Patient will not come to you and say, I have a glaucoma, right? A visual field. It's already confirmed that the test is reliable. Is it nasal?
Yeah. Okay.
So, what's your impression? What you will do? Where? Why you want to confirm that? Is it a glaucoma? This one. Do you want to see the other eye?
Yes.
Okay. So this patient is normal. He came just for screening, and we did this visual field. 20 or 24 or 30, they are good. If the 30-2 is reliable, it is good for glaucoma or anything else. Okay, but 24-2 will be shorter, so the patient will be more, the result will be more reliable, and it covers the areas we are interested in glaucoma. Okay, this test have very high movement of the eye. See the gaze here, so you cannot rely on it. Even if these is here are good, everything else is good. You cannot rely on this. Another thing, refraction is not mentioned here. Okay, you should pay attention to everything. We repeat the test. This is normal. Refraction is corrected. All pass. What do you think now? Is it normal or abnormal test? الاريا اللي كان فيها سكتومس it's normal.
So would you go on and back into the one more back?
So,
Yeah. Actually, this one, if you see like this changes, you should look at the other eye. Despite this one, I mean.
yeah, and these same
See,
changes. Yeah.
So it could be by temporal hemianopia early on, and you don't want to miss a chiasmal lesion that the patient could die because of this.
Yes.
So even there is a minor chance, but the chance to lose the patient is big. And if you lose the patient, and the patient complains or his family complain, you may lose your license. This is not a game, okay? So always look at both sides. And if you have like this small temporal changes, think about a neuro things because it's respecting the vertical midline, not
Yeah.
the horizontal one. Yeah. Okay, sorry.
Yes. Okay. Okay.
Maybe
So
we can end by this one,
Huh.
the last one.
this is the last.
Yeah.
Okay, quickly you can take this.
Any volunteer?
Jane here.
And she is not with us this month.
Okay.
Arwa. أروع.
So this is the same visual field for the same patient, but in two different time points. What do you say here? What do you see here in this field? Just tell me, يعني, the finding. You don't need to read the whole.
Yeah.
Okay. Okay, but describe the scotoma. Okay, so you see it's central scotoma. Where mainly? Which quadrant? Temporal and peronasal. Okay. Say this is paracentral scotoma. If the patient vision is good, the 10-2, it's not reaching the center, so we can say it's paracentral scotoma. And the patient repeated the test a few months after, and he had this field. What do you think? So let's see the same scotomas and compare them. He has paracentral here, still there. This one also, this is a little bit less, but it's still there. But there's something changed. All of this came up. What is this?
What do you think?
Our peripheral field became more restricted.
Okay.
And the mean deviation.
What do we call it? It is continuous like this. Close? Yes. Why does it happen usually? Okay. 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 Yeah, okay, but what else can cause this in visual field? Hamid? Yes, the lens frame. Especially he's using, they're correcting him for +3 and with cylinder also. So the rim of the lens can cause this ring scotoma. But he did not have it here. Why? They corrected him. Why it happens here but not here? They use the same lens. What happened? Sorry?
Yes, same prescription.
Same prescription. Position, I guess. Patient was not sitting correctly in the second exam. Always correlate your clinical and visual field. And you don't do one test and depend on it 100%. If your patient following him clinically is fine, normal pressure, the disc is fine, OCT is fine, and suddenly you see this change, you should dig and see why this happened. Yeah, this is one of the reasons can happen. If he has small pupil size, you can see it here. That is it. I did not mention here. But yes, if he has small pupil, he can have his own pilocarpine or something. Finished? Yeah. Okay.
Just I have a question from the resident. Arwa, what's the extent, the normal human visual field? What's the extent of the normal human visual field?
I think the way that was described by Dr. Shukran.
Thank you.
It's very nice having just highlights of the visual field. whatever, the way that Dr. Bader is starting, describing the visual field and